Hello, can you all hear me? Reese, can you go get my... Can you guys hear me now? Renice, are you done?
Yes.
Okay, good. Can you go get my phone off my bed, please? Okay, let's get started. Hi, everyone. How are you doing today? I'm sorry I got a late start. I worked last night and I didn't mean to oversleep, so. So today we're going to be discussing our endocrine system. And within our endocrine system, there's a complication, an emergency complication called diabetic ketoacidosis, okay? Here we have a case study. I don't know if you guys can see it, but here we have a case study of a person. Let's see if, can everybody see this okay, or is it not? Can you type in the comments if you can see the case study words or if you cannot see the case study words? Okay, too far away. Let's see if I can fix that. How about now? Is that better? Let's see how big I can make this. Okay. I think that should do it. Okay, now let's get started. I don't want to take up any more of your time. So, welcome, future nurses, okay? Because In my mind, all of you are nurses anyway. I just wanted to go over an overview of diabetes for for a minute. So we know that there is type 1 diabetes, which is insulin dependent, and there is type 2 diabetes, which is insulin resistant. Now, the difference is type 1, the body has no insulin at all. The beta cells are damaged, so they do not secrete insulin. They do not produce insulin at all, okay? Type 2, the body produces insulin, but the insulin kind of like closes its doors. So the glucose is like it can't get in, it can't pass through. We know that insulin is the gatekeeper of the cells, okay? They regulate cell metabolism from carbohydrates, which is broken down into glucose. We know that. From protein and fats, okay? That's the patho of type 1. Type 2, the insulin is there, okay? It's at the door. It's like behind the door and the glucose is trying to get in, but they're like, haha, I'm not letting you in. So the glucose just stays in the bloodstream, okay? And it builds and builds and builds until, you know, we have to use artificial insulin or man-made insulin to regulate the glucose now, okay? So that's the difference between type 1 and type 2. Sometimes you can control type 2 with diet only, and you don't need insulin. The overview to diabetes, to the endocrine system, is this. We as nurses, all we do is treat the imbalances, okay? That's where your nursing diagnosis come from. We treat the imbalances. Whatever imbalance that may arise, that's what we do. That's how we take care of our patients day in, day out, no matter if you're in long-term care or no matter if you're in a hospital or no matter if you're a home health nurse. Okay, you're still going to be treating the imbalance. So let's get started. So you are the nurse, okay, in the emergency room. Your next admission is Anne that comes into the ED. She has a blood glucose of 965. She has dry buccal membranes and a capillary refill of greater than 3 seconds. She says to you, you know what? My head hurts, but I ate a frog. And you looking like, okay. You take her vitals and her blood pressure is 99/54. Her heart rate is 123. Her respirations are 8 and fast, okay? She has a history of diabetes type 1 and has poor insulin control. What is going on with this patient? Well, we know that they're in DKA, okay? But there's some things that we need to do in order to confirm this first before we start our interventions. So now, as a team, New Nurse University members, we are going to take care of this patient and carry out the plan of care from admission to discharge, okay? So, diabetes type 1, what is the patho? I know I just said insulin dependent, but really break it down. Tell me what's going on with this patient. The patho is what's going on inside the body. I have the wrong thing here, but I'm gonna correct it. Oops. So if you had this case study in front of you and you were doing this at home, you would start off with the patho, right? This is how you do your case studies. I wonder if anybody finished their case studies at all. So the patho for a diabetic type 1 patient would be, I'm looking for beta cells. For those of you that can't see it, I'm trying to make it bigger, but it's getting cut off. Try to make your own screen as big as possible if you can. Is that better? But it's kind of cut off though. Yes, Danny, that's true. The body does have lack of insulin and it's breaking down fat for energy, which makes the fat turn into ketones. Why does the body have lack of energy? I mean, lack of insulin. Tell me why. Okay. So the beta cells are damaged. That's why diabetic type 1 patients do not have insulin. So beta cell damage, right? So if you were doing this case study at home, you would be typing in beta. And then you would also type in something short and simple, something that you can remember, something that you can, go back over 2 days before your NCLEX or your test, your nursing school test, and say, oh yeah, okay, I remember why now. Are you guys doing your case studies like this for the people that have purchased case studies or the study plan? I hope so. Okay, so Anne is your patient now. So tell me, come on, y'all, let's go. Type in the comments. We see that she has a glucose of 965, okay? 965. What do you think is what do you think the nursing diagnosis is going to be? Let's use something with dehydration. Somebody tell me a nursing diagnosis. Somebody type in risk factors. Okay, what triggers this? Modifying and non-modifying. Claudia. Okay, let me recap for you. So this is a case study about DKA, okay? We have a case study, we have our patient here, and you are the ED nurse, Claudia. So Ann comes to you in your ED with a glucose of 965. She has dry buccal membranes, okay? Her capillary refill is greater than 3 seconds, and she says to you, my head hurts, but I ate a frog, okay? And you're looking at her like, okay, lady, that doesn't make sense, but I'm just going to keep assessing you anyway, right? So you do her vital signs, and blood pressure is 99/54, heart rate is 123, respirations are 8, but they're very fast, okay? Deep and fast, rapid. And she has a history of diabetes type 1 and poor insulin control. So we're creating a care plan for this patient so she can be admitted, and then we're going to go through the process and then discharge her, okay? Trina, yes, very good. Fluid volume deficit, absolutely. This patient is dehydrated. How do you know she's dehydrated? Come on, type it in the comments. How do you know she's dehydrated? What did your case study tell you? Claudia, yes, absolutely. Infection is a risk factor, okay? It's the number one risk factor for DKA, okay? Obesity is another one. High blood pressure is another one. Sedentary lifestyle is another risk factor that can trigger DKA in a diabetic type 1 patient, okay? I bet you didn't know this. Acute pancreatitis, something as simple as having diabetes type 1, but you develop acute pancreatitis, it means your pancreatitis is no longer working. It cannot do what it's supposed to do. Acute pancreatitis can lead to DKA, okay? Absolutely. Also, starvation. Starvation can also trigger DKA. Let's say an obese person is trying to go onto a diet, and now they've gone from eating, 4 or 5 meals a day to 1 meal a day. Well, that's not going to be sufficient enough glucose, right? It's not going to be efficient enough, and they're going to deplete the fat stores. They're going to deplete the fat store. So that's how an obese patient can develop DKA through starvation. Okay? Does that make sense, everyone? Okay, so our another risk factor would be alcoholism. A lot of people that have alcoholism drink and drink and drink, and those empty calories, guess what? It's not helping. That leads to starvation. Most alcoholic patients do not eat. Okay? That is another risk factor for a diabetic type 1 patient that could lead to DKA. DKA is a medical emergency. So you may have many factors as to why this patient and your patient in the ED came with a blood glucose of 965, dehydrated with a low blood pressure. Okay? Do you guys see that? So our nursing diagnosis is fluid volume deficit related to what? You guys know this nursing diagnosis from your care plans. Come on, don't act like you're never going to use them. Related to what? So the related to part would be something like your patho, I guess, would be your patho. So you can say fluid volume deficit related to dehydration as evidenced by dry buccal membranes and capillary refill greater than 3 seconds. Do you see how I'm putting this together? Do you see how I'm connecting the dots, guys? This is what the case study does. This is what your checklist does. Help you connect the dots, okay? We got our patho, which is beta cell damage, which the pancreas cannot produce insulin. Fat is being used for energy instead of glucose. Our nursing diagnosis fluid volume deficit, related to dehydration, as evidenced by dry buccal membranes and cap refill greater than 3 seconds. These are simple notes that you can make with this case study, with this checklist, and review in a matter of 15 minutes before your test, okay? So we talked about our risk factors, obesity, alcoholism, starvation, infection, acute pancreatitis. So you cannot say that we did not go through your risk factors. I don't know what risk factors are. Yes, you do, because they'll be right here on your sheet. I can guarantee you almost going to get a question about DKA and risk factors while you're studying, okay? Okay. Now, everybody asked me about potential complications. What things can come about when you have diabetes type 1, you're in DKA? What potential complications? So potential complications are not signs and symptoms. Let's get that straight right now. Potential complications are things that arise after the damage has been done. She's already in DKA, guys. 965 glucose, she's already in DKA. What's something else that could happen? Look at that blood pressure. Tell me what else could happen to her. She's already dehydrated. We can see that by her blood pressure and her dry buccal membranes, right? What is something else that could potentially happen to her? Is everybody on the same page? Is everybody liking what I'm putting down? Is everybody, come on, give me some hearts now. It's dry. Absolutely. Kidney failure, renal failure. Yes, absolutely. What else? We worried about that blood pressure. Thank you, Nash. We are worried about the potential complications of shock. If this patient goes into shock, all organs will shut down, and that's another problem. They'll be in mods, okay? We are worried about low cardiac output, shock, sepsis, all of that. Now, how is this patient going to present to you? So we already got some signs and symptoms, but guys, if you really take a moment and think about how this patient in DKA is going to present to you, not all of the signs and symptoms are here. So give me some signs and symptoms that are not here. And let me explain to you something about DKA. There are 3 types of DKA. You have mild, moderate, and severe, okay? What would be some mild DKA symptoms? Mild, the way you determine that if it's mild or not is by your pH, okay? Your pH will be between 7.25 and 7.3. That's mild DKA. Even though her glucose is 965, if her pH comes back and it's between 7.25 and 7.30, it's mild. Tell me some mild. Yes, Danny. Oh my God, yes, honey. I got to like that comment. Your 3 Ps. Mild signs and symptoms for DKA is polydipsia, polyuria, and polyphagia, okay? Excessive thirst, excessive hunger, and excessive urination, okay? Yes, some more signs and symptoms. Okay, we're gonna get to the fruity breath. Moderate. What are some moderate signs and symptoms? Fatigue. Absolutely. Fatigue. I'm tired. I don't know what's going on with me. They're going to have tachycardia. And hypotension, okay? Now, severe. Absolutely, Claudia. Blurred vision. They're going to have the fruity breath. And they are going to be confused. Now, let's go back up to the top. What does our patient have? She got mild, moderate, or she got severe DKA? Let's somebody tell me. Antoinette, how do you know she got severe DKA? How do you know? Because that glucose is not going to tell you alone, okay? The glucose just does not tell you alone. We have a combination of things we need to figure out here before we can, really diagnose her with DKA. How do we know it's severe? Tell me. Yes, absolutely. She ate a frog. You looking at this patient like, okay, now we gonna get back to that eating a frog thing in a minute. Yes, your patient is confused. Okay, so that's it. Confusion should trigger something in you as a nurse. If your patient is confused, you should automatically think something is wrong. Okay, some type of infection is going on. Some type of, imbalance is occurring. Okay, absolutely. Her respirations. Did you guys pay attention to the respirations? They ate, y'all. They ate. And she's breathing fast. What is that called? I can guarantee you on NCLEX or your nursing student test, or your nursing school test, they have a name for it, especially for this DKA patient. What is it called? The respirations that are deep and rapid. Thank you, Shirley. Yes, Kusumo breathing, okay? That is how you know your patient is also in severe DKA. Okay, let's go back to moderate. The pH is going to be between, it's going to be less than 7.3. And then for severe, the pH is going to be less than 7, which is very, very bad. I want you guys to know, if you have somebody with an acid-base imbalance and their pH is going down, what did Mark Clemec say? What did he say? They basically dead. It's either you alive or you dead. That pH goes down. That's it. So you as the nurse, we have to maintain this pH. Okay, we absolutely have to maintain the pH. So yes, it will be up after this. It absolutely will stay up. Okay, so now we got this patient, and now we gotta run some labs. We as nurses, we can't do nothing without the labs coming back. Okay, So we already took her blood glucose, okay? Let's say we did an AccuCheck. And it is 965. What else do we do? What else do we do for this patient as far as labs and diagnostic tests? Absolutely. We are going to test for ketones in the urine, or they could just be ketones in the bloodstream. It's called a ketone, I think it's called a ketone body test. And then we absolutely going to do ABGs. Thank you, Nash. Very good. So we know that our CBC takes care of what? What does our CBC take care of? What are we testing for? What are our hematology labs? You guys are going to learn this when you get on the floor. Which ones do we get the potassium and the sodium from? Which ones do we get the BUN and creatinine from? What's inside these tests? So we can name the tests, but do we know what the tests are for specifically? Come on, that's why we doing this. We doing this to get clarity, okay, guys? CMP is your chemistry labs. Your CMP brings back your renal function tests. So BUN, creatinine. Your CBC does your potassium, sodium, chloride. Y'all don't know what's in these tests? When you get the test back, what labs are you looking for? Okay, we absolutely want to know about the potassium, sodium. Thank you, Claudia. Yes, H&H. Okay. Danny, what's in a CMP? Which one? Okay, let me move on. Okay, so now we done all this research for this patient. Now we need to treat. You as the nurse, you absolutely have to do something for this patient. Okay, now we're going to focus on airway, breathing, and circulation. First of all, we're going to what are we going to do for her breathing? Breathing comes before fluid. Breathing and positioning comes before fluid. So what are we going to do for this patient? Come on, give me some interventions, nurses. You know this stuff. Yes, thank you. Oxygen. Okay, how are we going to position this patient? It could be semi-Fowlers or high Fowlers. As long as the head of the bed is elevated. Great, 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 great. Now, our number one priority for DKA is fluid resuscitation. Why? Tell me why. Number one priority for NCLEX and DKA is fluid resuscitation. Let me say that one more time. If you don't pick fluid resuscitation for DKA, now let's just playing. Guys, you have to pick up on the patterns when you're studying these systems, okay? Number one priority is fluid, fluid, fluid. Okay? Aggressive IV fluid. What are we going to hang? This patient has 965 glucose and dehydrated, going into shock. You see the blood pressure is low, tachycardic, not breathing well. We already gave the oxygen. Come on, guys. What fluids are we going to hang? Yes, 0.9. Now, are you going to get this wrong on a question? Please do not get this wrong on any question. It is 0.9 normal saline first. The second bag can be 0.45 or half normal saline. Why? Tell me why. Why would we give 0.45 normal saline? What electrolyte has to be off in order to give 0.5 normal saline? Can you tell me? Think about what's in saline. Come on, guys, you know this. This is easy. What electrolyte is off if we're giving half right? Claudia, think about your electrolytes now. We're shifting. So if you're giving 0.45 normal saline, your sodium is too high. Okay, if your labs come back, so your CBC came back and your sodium is 165. That's high, right? That means that the kidneys is messing up. If your BUN and creatinine come back and your anion gap is elevated, your CMP come back, BUN creatinine is high, anion gap is elevated. Something's wrong with your kidneys. They're not perfusing well, okay? They could be potentially getting ready to shut down. Your sodium is going to be retained, right? Sodium is going to be off. It's going to be retained. It's going to be high. That is why we give 0.45, because your sodium is high, and we do not want to put this patient in overload. We do not want to put this patient in fluid volume overload. So that's why you would give 0.45 normal saline. But originally, the first bolus for a DKA patient is 0.9. Okay. So now, what's the next thing we're going to hang? Now we're talking about medications. What do we hang for a DKA patient? Shirley, you thinking about hypoglycemia. It's the opposite. Dextrose and glucagon is for the hypoglycemic patient. Insulin. Which insulin? Am I going to hang a long-acting insulin? Am I going to hang a rapid-acting insulin? Am I going to hang an intermediate insulin? Long-acting is your Glargine, your Lantus. Fast-acting is your Lantus, your Lispro. You know, the one 15 minutes before meals. Let's see. Novolog is your intermediate. Come on, guys. NPH, you know. Which one? Short acting, rapid acting. Yes, Claudia, good. Rapid acting, normal, regular insulin. Very good. Very good. So you guys know that you hang the normal saline first, and when that's done, you hang the insulin. Oh no, it says simultaneously. You can do it simultaneously. Okay. This patient by now would be in where? Not in the ED anymore. Okay. This patient would be where? Where would this patient be transferred to? Discharged to? Thank you, Claudia. Absolutely. To the ICU, because ED nurses, they hang drips, but they don't maintain them. Okay. That's for the ICU nurse. ICU nurse will maintain that insulin drip with the normal saline drip. And now we're into critical care. So you got an insulin drip and you got a normal saline drip. What parameters are we looking for this patient to go back down to? In critical care, the parameters are different for a patient that's in DKA. So what parameters are we looking for? How do we know that these ketones are resolved in this patient in order for them to be able to go out of ICU and discharge somewhere else to another floor? We're going to test the blood glucose, right? So what's the range? What range should we be at? So we want this to go down to 200, okay? 200 is a safe range for a DKA patient on an insulin drip. You guys need to remember that, okay? But when you get a critical care question on NCLEX or in your nursing school test, and they're asking you, okay, this patient is in DKA with a blood glucose of 200, that's normal. That's normal for the critical care patient. Okay? That's normal for the critical care patient. You guys need to remember that. After the level has decreased to 200, the acidosis has been corrected and rehydration has been achieved. This takes 2 to 4 hours to do, guys. It doesn't happen right away. You definitely don't want to put them in a hypoglycemic state. So what do we do after they have reached the therapeutic threshold for a critical care patient at DKA of 200? What do we hang now? Yes, Claudia, that's the fluid that we want to hang, but can you be a little bit more specific? Is it D510? Is it D5 normosaline? Is it like, what is it? Okay, so Rachel, you're thinking about dextrose, the 50, the D50. That's for a hypoglycemic patient. We would be doing D5W for the fluid now so that we don't put this patient into the hypoglycemic state along with the insulin drip. Insulin is always hung on a what? What is insulin always hung on? Are you going to free flow the insulin? You're just going to let it hang? In a critical care patient, also, how do we assess ABGs? We're going to keep sticking the patient? A pump. We are going to put it on a pump. Never, ever, ever run insulin without a pump. Just like mag, just like potassium. Okay? You never run those things without a pump. How are we going to assess these ABGs, guys? Come on, we got to think a little bit deeper. We're going to keep sticking the patient every 2 hours to get ABGs. What do we have to put in for this critical care patient? What kind of IV access? What kind of line do we have to add? A PIC line or what? Central venous pressure. An arterial line. An indwelling arterial line. Okay. It's going to provide hourly sampling for arterial blood gases to show whether the pH and the bicarbonate and other labs are elevated. That's how we keep assessing our critical care patients. So not only does this patient have 2 drips going, they have an arterial line, and they're still going to be NPO in the ICU. We need to reassess our patient for what? What should have went away? How are we going to reassess our patient? What are we going to be reassessing? Orientation, confusion, absolutely. We want to see if the confusion has went away. We want to see if her dehydration has gone away. Okay, so not only is she going to be having an arterial line, she has drips. You as the nurse also have to assess her hourly intake at this point. We want to assess blood pressure changes, blood glucose, her skin turgor, right? Because what do we say? It was capillary refill was more than 3 seconds. We have to reassess those things before we move them anywhere. We want to document and say that they're getting better. We want to document that we are educating them on what's going on with them. Even though that the patient may be confused, you still have to educate your patient. Now, what are we going to teach this patient while they are still confused? Or if they're coming out of their confusion, what are you going to tell them? What are you going to tell them what happened to them? How are you going to document that you educated? That's what lawyers are looking for, that you documented education. Educating is a 20, as long as you're on your 12-hour shift or however long your shift is, you better be documenting that you educated about something. Okay? What are we going to tell this patient? What does this patient need to know at this point in their recovery? First, we need to assess what the patient knows about diabetes. Maybe they don't go to the clinic as often as they should, okay? Maybe they don't even know they have diabetes. We need to know what they know, their knowledge level. Okay, we need to know what they know. So yes, ask them questions about what they know about their diet and their diabetes. Hey, Miss Ann, did you know that you were diagnosed with diabetes? Has anybody ever told you about diabetes? Yes, I know I have diabetes. Well, how often are you getting treated for it? Well, I'm supposed to go to the clinic, but my feet hurt. So, I don't like to get up I don't like to get out of the house. I don't like to go out of my house. because my feet hurt all the time, and I'm kind of overweight, so I don't like to walk anywhere. Well, did you know they can have transportation come pick you up? Let's see what a case manager can help you with. Is there anything else you might need to know about diabetes? Come on, let's get a dietitian or an endocrinologist on board to talk to you about this, right? These are referrals that we're bringing on, right? She might need a dietitian, or she might need what else? Well, my vision is not that great, she tells you. Now who does she need to talk to? If her vision is going down, she revealed that to you during the education. Who do you need to get on board now? Ophthalmologist. Exactly. These are the type of questions that NCLEX and your nursing test are going to be asking you about, okay? Especially for the diabetic DKA patient, okay? These are the referrals and the consultations that they're going to be asking you about. This is the interdisciplinary team that NCLEX loves to throw at us all the time. Ophthalmologist, dietitian, okay? She's telling you her feet hurts. You need to assess that further. Well, what kind of pain is it? Is it a numbness, a tingling? Is it a sharp shooting pain? What kind of pain is it? Now, who does she need? Podiatrist. Absolutely. Neurologist. Absolutely. We need to know if she has neuropathy. We need to know if she needs care for her feet, if she has neuropathy. All of these team members are your interdisciplinary team, and the diabetic patient needs all these people, okay? That's the person you're going to pick when they're asking you about the diabetic patient and who needs the most interdisciplinary team members. What if her family is there with her? What if her dad shows up and says, wow, I didn't know you had diabetes. What are you going to teach the dad? Now we need to get who? Who do we need to get a referral to? About her housing. And what if the dad asks her, well, where are you staying at now? Because maybe they've been estranged for some time. Who do we need? A social worker. Thank you, Valerie. Look at all these people who we have to involve in this woman's care. It's not just cut and dry, okay? We need to assess, it falls on us to assess all of these things. We need to assess for the social worker. And this isn't any patient, guys, not just with a DKA patient. If you want to know what you should be teaching your patient, what you should be educating your patients on, any med-surg patient, these are the people, case managers, to see what kind of tools in the community they can use. Okay, maybe they need a bedside commode. Maybe they need, maybe she needs a insulin pump. She needs to know where she can get a free insulin pump. The case manager would know that. Maybe she stays in a shelter. The social worker will help her with that. Maybe she was telling us her feet hurts or whatever, okay? These are the people that we should be educating our patient about. These are the people that we need to bring on board, okay? And then before she leaves, we need to know she knows how to take care of herself. And you guys were absolutely right to say she needs to know signs and symptoms of diabetes or hyperglycemia, hypoglycemia, and DKA. So she needs to recite back to us what she knows. She needs to recite back to us if she can hook up her insulin pump correctly. Okay, what if the social worker, what if the case manager come down and say, "Hey, I went to I went to this place and they donated 40 insulin pumps to us. I'm going to give you one for free." It's up to the nurse to teach her how to use it. Does that make sense, you guys? Absolutely. Brochures, videos, pamphlets, all of that good stuff. I hope this is making sense to you. Can you give me some hearts if this is making sense to you guys? Is anybody confused about anything? Thank you. I hope this was very helpful to you guys. And this is exactly how you guys need to be filling out your case studies, okay? If you haven't gotten your study plan yet that comes with the case studies, go ahead. Don't be afraid. It's just another learning tool. I know you guys are, tired of all these learning tools and everybody got something for you, but if you simply buckle down and stick to it, you guys can do this, okay? You guys can absolutely do this. Was this helpful? Do you guys see how you can take your patient from admission to discharge? Okay. This is how you do it. All right. It connects the dots to so many things. We talked about patho today. We talked about, we even threw in a nursing diagnosis. We talked about risk factors. We talked about potential complications. We talked about lab values, signs and symptoms. We even talked about patient teaching. We threw in medications. You see how your medications relate to DKA? Absolutely study your medications with your diseases. That's how you remember better. All week we've been talking about endocrine. We did hypothyroidism, we did Cushing's disease, and diabetes. I hope this was a helpful week for you with diabetes, but now we need to move on to mental health, okay? We have so many questions about mental health. So go home, or if you're at home already, you should be. You guys do some endocrine questions and see if this has helped you. If you missed, well, they're not videos. They're just posts of me asking questions. Okay, go do some questions and see if you don't improve by doing a endocrine case study. See if you don't improve. You will. I promise you. If you keep studying like this, you will improve in your content, and you will improve in your questions, and you will become consistent. Hi, Doreen. I'm so glad you was able to make it. Valerie, oh my God, that's so great. Welcome to nursing. I'm so proud of you. That's wonderful. Congratulations. Okay, you guys, that's our plan of care for this DKA patient, and I hope you save Ann's life, okay? This is very important, studying to save a life, not just to pass tests, okay? We want to make sure that we know this information when we're going to the floor, because as new grads, they already doubting us, okay? They're already doubting new nurses when we come to the floor. So this is how you study to save a life, okay? You got to include all this stuff. Don't be lazy. Complete the checklist. If it's something that's on here that you can't complete, skip it or try to see if you can complete it, okay? I'm Renee Dyson, your nursing coach. If you have any questions, feel free to inbox me. I'll try to get to you when I can. I have a lot of inboxes, guys. I'm sorry if it's delayed. If I ask for your email, it's for a specific reason. Give me some time to email you guys on different things that I have coming out, okay? And I hope this was helpful to you. Good night.